Thank you. Thank you, Dr. Sabri. That was a lengthy introduction. Thank the committee for inviting me to give a talk. As John Cleese in Monty Python would say, and now for something completely different. I don't have any conflicts, but I have confession. I'm not an avid regional anesthesia practitioner. My last, I still do regional anesthesia, but not as complicated as what is being presented now here. I did venture into giving cervical thoracic epidural for awake coronary artery bypass off pump. I've done that quite a few, and I've stopped doing that because the surgeons are becoming more aggressive and the patients are less prepared for these kind of things. We've done quite a fair bit, and I presented it in the past before. Okay. I'm here not to intimidate you all, but to reassure you, because every time I give a medical legal talk, and everybody will tell, why do you tell us all these things? But to reassure you, regional anesthesia is the way to go and it's the future. And I think we need more data to get our foundations correct and make that part of everyday practice rather than interested people only. Okay? Okay, I know we are lacking of time, so I'll just go quickly. I think everybody knows the history of regional anesthesia. It was popular and from beginning of the century until about 1940s when muscle relaxants come in and they are better at giving muscle relaxants to the muscles when surgeons are operating on big bulk muscles. And general anesthesia came in and regional anesthesia was still popular. Unfortunately, in one country, which we are governed by, which is UK, a series, or rather a case, two cases happened that put regional anesthesia set back quite a few years. And this is the Roe and Woolley and Roe case. And for those of you who have not read about Woolley and Roe, these are two patients which were admitted, and regional anesthesia at that time was becoming very popular. Both of them, one after another, anesthetized by the same anesthetist, using the same spinal technique, using the same spinal anesthesia for the surgery when successful. But the outcome was devastating for both the patient, the anesthetist, and also for the practice people who are interested in regional anesthesia. Both of the patients did not recover from the spinal anesthesia. In fact, both had paraplegia. And that was a great headline news in UK, and that set back the progress of regional anesthesia for a long time in UK. Unfortunately, we followed UK standards, so we were very reluctant to do that for a long time. And they didn't know what happened, why these two patients had paralysis after spinal anesthesia. And the great Professor McIntosh, at that time, his word was God's word in anesthesia. And he postulated that the ampules that they stored the local anesthetic was kept in sterility by putting them in phenol. And the phenol may have gone through the cracks. That was just a theory, but nobody knew about that. And because of that, the anesthetist, the lone anesthetist, was not held responsible because at that time, nobody knew about it. Therefore, he cannot be held negligent for it. And so, Roe and Woolley, even though they had this catastrophe, they received zero compensation because there was no negligence. And this sets up two very important things in medical law. Number one is the Bolam law, and number two, what Lord Justice Denning said. The Bolam ruling is that if you are an anesthetist and you practice what anesthetists in your profession do, then you're not negligent. Therefore, at that time, we do not know that these cracks can happen, and it did happen, then it is not the fault of the anesthetist. And as we progress through the time, you will see that as we subspecialize, the specialist in that subspecialty, when he does that, and everybody else around him agrees in that subspecialty that he did the right thing, then he is not responsible, he is not negligent. And the second thing that we must understand when Lord Denning said is that because the case came up about 7 years later, and most medical legal cases nowadays you have 6 years period before the patient sues you in private practice and 3 years in government practice. That's governed by Malaysian law. And the cases will come out 7, 8, 9 years later. And an expert witness at that time may say, in my practice today, I did this. No, you cannot use. You must use the standard at which the case happened. And this is well said by Lord Denning. He says, we must not look at the 1947 accident with a 1954 spectacles. So it cannot be retrospective standards. That is very important in medical law. Okay, so this case was re-examined again in 1990, and the person who did this was Dr. Maltby. He interviewed Lord Denning, who was the presiding judge in the Court of Appeal, and they come to a conclusion that probably Professor McIntosh was not right, probably the sterility of the syringes used at that time may still have some contamination from the contamination while they were cleaning it. So until today, nobody knows what happened. Okay, now back to Malaysia. If you look at the medical legal aspects of anesthesia practice in Malaysia, not many people have written it. Some of you, the senior, very senior doctors, may recognize that this is Dato Dr. Radha Krishna, my boss when I started anesthesia. Anesthesia those days in the early 1980s was traumatic. And if you get posted to anesthesia, that means you must have done something wrong, or you specifically asked to go to anesthesia, or you didn't want to get out of that area like KL. So where do you want to go? I want to stay in KL, also go to anesthesia. That's it. You got no choice. So anesthesia was a very unpopular role in the 70s and 80s. So Dato Radha wrote a paper on medical legal aspects of anesthesia specifically. And he looked at all the medical legal cases in this country until 1990. And of course, we would expect obstetrics and gynecology to be high on the list. Second is general surgery, and then orthopedics, and anesthesia is at 11% of all cases of medical legal suits that come in this country at that time. And what he did find out that the majority of claims in anesthesia was against junior anesthetists. And this is an issue when we had, even until 1980, 1990, we do not have enough anesthetists in this country because we do not have a postgraduate program. All our anesthetists who had to become anesthetists had to go to UK, work there, get the fellowship, and then come back here to be called anesthetists. So we do not produce. In contrast to surgeons or physicians, they can sit for the exams in Malaysia, get their exams passed, and still be called specialists. Whereas in anesthesia, before you can sit for a fellowship in UK, you have to work there for at least 1 year to be classified eligible to sit for the exams. So there's not many anesthetists. The common causes of death at that time is usually under general anesthesia, aspiration, gastric contents, difficult intubation, airway problems, and things like that. And to note, there was not a single case of regional anesthesia medical legal negligent case brought up. Okay? Now, a large portion of this medical negligence was settled out of court. Therefore, it was not known what the cases are, how it was done. Therefore, there's a large repertoire of knowledge which is lost on how we can improve our specialty to correct what was wrong. So because of this, the progress of safety in anesthesia took a long time in this country. Okay, now let's have a look at litigation, real published data in UK. If you look at the first paper published in 2012, you will see the same thing like what Dato Radha has written. Number one on the list is ONG, surgery, emergency medicine, then only it comes to anesthesia. Okay, don't be fooled or be comforted by this, because when an ONG guy goes to court, he will bring you to court as well. When a surgeon goes to court, he will bring you to court as well because you anesthetize for him. So in actuality, the most attended person in court is the anesthetist. All right? So what we see from this data is that 2.5% of all claims are anesthesia related, and 2.4% of all claims are anesthesia related. So that is quite comparable, okay? And if you look at the 2.5% of all claims, which are 841 claims in 12 years in the UK, 44% were related to regional anesthesia. And 29% is related to obstetric anesthesia, which majority involves regional anesthesia. So that's a bit surprising. Okay? And of course, the other complications from general anesthesia are there. You can see that central venous cannulation, consent. Consent is becoming a big issue, and a lot of times I get called to give medical legal talks. It's mainly about consent. People are still confused. I'm still confused about it, but I give talks on it. Okay? And if you look at it, the number one cost in terms of monetary paid out is still regional anesthesia, 11 million pounds. And the highest for cases of regional anesthesia exceed £500,000. Therefore, when things happen in regional anesthesia, the cost is catastrophic. Okay? And these are some, I'll go very fast because I know everybody wants to have a break after this. And these are some of the causes of events in medical negligence: regional anesthesia, nerve injury, inadequate blockade, and epidural-related problems. And as we see now, with the advent of ultrasound and ability to pinpoint, this should come down. Therefore, the way forward is to be able to say that I have seen it and it's not there. I have not damaged the nerve. Previously, it was all blind. Okay? Now, if you drill down into those cases of regional anesthesia alone, we will see that if you analyze the regional anesthesia, you'll see that fewer claims of fatal outcomes in regional anesthesia compared to general anesthesia. Now, why is the cost more then? When you die, you don't pay that much. But when you have a paralysis, they have to pay you for income that you're going to earn, upkeeping of your health benefits and things like that. You're taking care of yourself. So the cost of non-death neurological complications is much more compared to if the patient dies. Okay? And when regional anesthesia goes, it is difficult to claim because more than 3/4 are closed, and usually it is against the doctor. Okay? Most of it is epidural, spinal, and combined spinal and epidural. At that time, it was just coming up during the early 2000s, but mainly epidural. Okay? Total cost, still epidural, is about £8 million. Total. Okay? Now, again, I will go through this. It's no point me reiterating this. Nerve damage, pain, back pain are the ones that are the main problems, that the main complaints that the patients come to you for. Okay? Death. There are deaths in non-obstetric anesthesia, 5%. Okay? So there is an issue there somehow. Total spinal, not recognized, hypertension, late recognition. Okay? But the obstetric anesthesia, quite safe. Now, 10 years after that, they reviewed again. A similar study, reviewed again, and this came out late last year. So they compared the 1990s and the 2000 data. And what did they find? Good. For regional anesthesia, in the later looking back, the amount of claims have dropped. People are becoming safer, or regional anesthesia is becoming safer. Okay? And obstetric anesthesia is becoming safer still. But Other things, for example, putting on lines, and the most important one is drug allergy is coming up on the list. We tend to give multiple drugs nowadays and a lot of newer drugs. So these are the issues. Not only the drugs, the way in which the drugs are given. Okay, so if you look at the summary between the two, the annual number of claims against anesthesia, the number of claims increased basically because the number of cases increased. Okay, the anesthesia basically is a smaller proportion of all the claims. Remember, the first one was 2.5%. The later half has come down to 1.5%. Again, the total cost of all claims have reduced. Unfortunately, the amount given has increased from, in 10 years' time, the amount has increased to 300%, 3 times. Even though the number of percentage has dropped, but the total claims have increased. And again, the most common clinical categories are number 1, regional anesthesia, inadequate anesthesia, drug administration. We have dropped it from 44% to 24%, but still, it's still number 1 on the list. Okay? All right. We'll go down. I talked about that. The regional anesthesia claims have reduced both numbers and proportion, but the costs to compensate have increased. The cost per case has increased 4 times because now the cost of maintaining neural damage, neurological damage has increased because the standard of living has gone up. All right? And surprisingly, 2 claims describe wrong route error. This is Beer's block, intravenous administration, large volumes of local anesthetics. Okay? Which not many people practice nowadays. Okay? So, in summary, for obstetric anesthesia, the numbers have dropped basically because they are better at it, but the central neural exit, neural blockade has dropped a lot more. Okay? Claims relating to consent has increased. That is why, even though we can reduce a lot of things, consent is a big issue nowadays. Did we inform the patient that these are some of the things that might go wrong? We tend to do things for the benefit of the patient, but it is the patient's choice to say, I want it or I do not want it. This is what we all forget. We try to do the good, but it's still the patient's choice. Okay? Other issues, basically because the lack of explanation of alternative treatments. And this is what is bugging the UK, the British anesthetists nowadays, because of the result of Montgomery. You all want to know about Montgomery, you can read about it. Montgomery is that she is a short stature woman who is diabetic, therefore has a big baby. The obstetricians didn't tell her that if she has vaginal delivery, the incidence of dystocia is higher than normal. Her alternative could be cesarean for a first baby. They didn't give her that choice. And because of that, the baby had shoulder dystocia and CP as well. And she sued because she was not told of. Therefore, consent information to the patient of alternatives and risks are not explained properly. Okay? Therefore, the 2017 Association of Anesthesiologists guideline says that adequate consent for anesthetic intervention, so and so and so, you must be offered to the patient. Okay? So, in conclusion, claims relating to obstetric anesthesia have reduced, but it's still high, probably because people who do obstetric anesthesia and analgesia, epidurals and things like that, are mainly by the junior people who are on call. Anesthetist consultants won't come in. So a lot of obstetrics happen outside office hours and given by junior people. Therefore, despite its being reduced during the elective days, the emergencies are the one that cause most problems. Okay? All right. If you look, if you look at the American data as well, and this came out about the same time that the second data from UK came out, you can see, but this is specific to central neural blockade. You see the obstetrics and orthopedics are still number 1 high up on the list when it comes to medico-legal negligence when in regional anesthesia, specifically central blockades. And again, technical knowledge and performance. Are they trained enough? Are they supervised enough? And the most important thing is documentation, which is missing. No documents, automatically you are looked and frowned upon. Very, very important, okay? And delayed specialist consultation is also dire. I must admit, when it comes to after office hours, you want to wake up your consultant, you think twice. Okay, that is one of the factors. Do not be afraid to call your consultant. Okay, in Canada, it's still the same. You will see that in Canada, this is about 7 years data, you see that there's about 80 types of regional anesthesia claims in Canada, mainly in perioperative, non-obstetric cases, and a lot of them is epidural and spinal. Okay. There are other things, brachial plexus blocks, stenate ganglion blocks, and things like that. And in Canada, there are cases coming out for chronic pain, and you can see that in chronic pain, the medico-legal is basically for steroid epidural injection for chronic pain. Okay, and the main reason, the big reason is that the contributing factors that we did not look into is number one, intraoperative hypotension not corrected or anticipated enough. Okay, history of patient comorbidity is not taken into consideration when you're doing your regional blocks. Okay. We teach everybody to do regional blocks, but not every patient can or should receive that kind, depend on their comorbidity. And this is not taken into consideration. Okay. And this is the Australian study. The Australian study is divided into two eras. One is the ERA, Australian Regional Anesthesia Consortium, 2006-2008. They have about 8,189 patients done under ultrasound and no ultrasound. So neurological deficits is 0.4%, two or three cases out of those thousands of cases. And the second phase is between 2008 and 2012. They combined the Australian data together from the data from New Zealand, and they have about 21,000 cases. And again, it shows that with ultrasound or without ultrasound, the neurological complications are very low. And if you combine those two data, you have nearly 30,000 data, patient data, and the neurological deficits is very low, 0.4. But when it happens to the patient, it's 100%. And ultrasound guidance, apart from causing nerve damage, also reduces intravascular complications from it. Okay. Lastly, I would like to talk. Lastly, I would like to talk about one case report. You can find case reports of regional anesthesia, but because I'm interested in cardiac, I'm going to talk about serious complications after epidural placement in a cardiac case. And this is a real case, but as I showed you, it never came to court because it was settled out of court. Like most regional anesthesia cases, it tend to be settled out of court. Therefore, we do not have good convincing data to reflect on. This was from the Medical Protection Society, which I'm quite active in. 70-year-old obese woman with a few issues had a bypass done in the past, so it's for a redo bypass. And the consultant anesthetist, Dr. E, pre-op assessment, saw the patient and told the patient that as part of his regular technique, he often inserted a thoracic epidural. It's good for post-operative analgesia and supports weaning off from the ventilator. Mrs. M was uncertain about the epidural, but she didn't ask any questions. And since Dr. E assured her everything will be all right, yes, she agreed to that. Bypass was done as usual, epidural, and it was inserted before the anesthesia. Bypass was done, cabbage was done with heparin given, on bypass, off bypass, everything came all right, no support and things like that. She was weaned off in the ICU. The next morning, she was okay, no pain. They extubated her, sedation was removed. And the nurse noted that Mrs. M was moving her arms, but not her legs. Red light. Okay, the nurse documented Mrs. M could not feel or move her legs. Mrs. M seemed comfortable. Now, this is what happens when you have one person in 10 doing a special procedure, but post-operatively did not specify to the general nursing care that these are the things you have to look out for. If you are doing a high volume, everybody knows your system, your standard operating procedure. But if you are the lone wolf doing something different, the others should also know what you want to do. This is the issue, okay? So at lunchtime, Mrs. M still did not move her legs. Only then the nurse called Dr. E for advice, and Dr. E was in theatre doing a second case or third case, unable to attend. And what did he say? Immediately he removed the epidural catheter. Okay. Dr. E couldn't come out, sent his registrar, who arrived an hour later, so that's another delay. Examined Mrs. C, found dense motor neuron issues, sent for a CT scan, came back, epidural space, had big hematoma down there, neurosurgical went in, took it out, decompressed it, but Mrs. M did not recover. Okay? When questioned, Mrs. M insisted that she had never been warned of with this complication. Therefore, she brought the suit against Dr. E. The expert's opinion was critical because, number one, the ICU records were not well kept. This is a real story, so I cannot go into detail even if you ask me questions. These are the published things, okay? Now, why? Because Dr. E and the surgeon went and did a post-op round but did not document in the ticket. And the nurses should be warned, these are the things to be looked for, but they did not warn because the nurses' turnover is high and they took time. So the delay is the one that causes the problem as well. And they questioned the wisdom of Dr. E to remove the epidural prior to the CT scan because they want to see whether the epidural was at the level of the hematoma or not. I know of cases where you put an epidural at one point, but then a problem happens at a different point, and they're trying to blame the epidural for it. But when the epidural is not there, you cannot blame it. All right? So they settled it for a high case, okay? So the lesson to learn is that doctors must take reasonable steps to ensure that the patients are aware. That is why consent is becoming a big issue nowadays. When you do regional blocks and things, whatever it is, you must emphasize on the patient, I'm doing this for your good because the post-op analgesia is good. But if the patient asks you about complications and things like that, risks, it is your duty to tell them. So they're not going to turn around and say, I asked him that and he says everything's going to be all right. All right? And it is the doctor's responsibility to give clear instructions to the nursing staff when delegating a task, specifically if the nurses are not seeing this as a routine normally. Okay? Okay. So I'm going to finish it in a short while. 15 years of ultrasound guidance in regional anesthesia, published recently, showed that ultrasound-guided regional anesthetic techniques are now fully integrated into everyday clinical practice. It's highly effective and safe. Agreed. But you still have to protect yourself. Okay? Technological advances, specifically in the design of ultrasound equipment, allow clear visualization of the majority of nerves. Therefore, you are safer, isn't it? You're doing this not blind and things like that. So you're safer is better. There's an increase in ultrasound, regional, okay? And this may be an issue because there might not be enough training and people go out and do it. There might not be enough supervision and it might see an increase, it might not see an increase. We do not know yet, okay? So the increase in interest, because there's a lot more going on, we should publish more. This is what the professor has said just now. There should be more publication to support what we are doing is correct or not correct. All right? And to further develop the science in the art of regional anesthesia, it should if it's good support that you have published, then we can incorporate it as a standard operating procedure for all general anesthesia. Okay, so the take-home message is that not all negligent events lead to a claim, and a claim may not be associated with harm or poor practice. Some people just sue. I've got cases where in the Australian one, which is even worse, the anesthetist was sued because he took 7 attempts to put an epidural. But he got it, but the discomfort. Okay? Clear instructions to the staff. I mean, taking consent is one of them. Good documentation. I was talking to the people outside just now. I was saying that maybe when we do the ultrasound, in our ultrasound, they can print out the picture of the local anesthetic that had been given. And if you use a pressure to measure when you inject, number one. Number two, and if you have used a nerve stimulator when you're using your ultrasound, just record that down. So you are really, really protecting yourself. Documentation is the lawyer's cornerstone of your defense. Okay? So very, very important when you talk to patients, I think my time is up, that you tell them that they understand your lingo and what you say. All right? Thank you.